So now we're going to talk a little bit about cardiac tamponade versus pericarditis. So basically when we're looking at the both, pericarditis basically presents a little bit differently. They're both going to be similar across the narrative of what they do. They're working around the same area. But we're going to talk about what is pericarditis, what is pericardial tamponade. How do they present? How do we differentiate them? Because a lot of the cases, they're going to be similar as far as their presentation and some of their signs. So how are we going to differentiate that? How are we going to treat that? What's going to be the difference too? So when we're talking about a cardiac tamponade, there's basically what I call an actual and a pseudo tamponade. So an actual tamponade is when we get an accumulation of fluids within that pericardial sac. So we have our lining around the heart. Our heart sits in there. There's a normal amount of fluid that's normally in there. That allows that heart basically to beat and contract inside there. When we get excessive fluid pushed in there, basically it fills that sac, but that sac can only stretch to a certain amount, correct? So that fluid now is going to be pressed against the heart. So just imagine now this fluid is in there. It's giving that heart a big bear hug. How easy is it to move my arms like this? Pretty easy, right? Now I get someone start putting their arms around me, it gets a little bit harder to move my arms against, right? Now I get someone giving a full bear hug on me, I can't really move my arms at all. Realistically, it makes it more difficult. That's one of the routes that it can come into. Yeah?
Is the normal amount, how much is normally in the heart, and that's normally what you get with cardiac tamponade?
No, that's the normal amount that's filling the sac. Yeah. So 25 to 30 mils is the normal amount of fluid that's surrounding that area. And it's a different, it's not usually blood, it's more of a clear fluid that comes around that. And it barely lights up. If you do an ultrasound on that, it doesn't really light up really bright because it's a small amount and it's distributed around the entire shape of the heart. But that is normal amount. Good question. Now, once that gets bigger in size, though, that can press on there. Two things start to happen with that. One, as you get more fluid into the heart, it does give that sac a little bit of a stretch. So that sac is designed to stretch a little bit, but it only goes to so far. So once I stretch that a little bit and that heart beats, what do you think that heart is doing inside there? Well, what it's doing is it's actually able to move a little bit more because the heart's stretched and it can move in the fluid. It's shifting that fluid out because that sac's not completely full. Just imagine that it's got a normal, it's put an apple in a plastic bag with a little water that surrounds it. It can move around. Add a little bit more water, that apple might move around a little bit more because that sac stretches a little bit more. So there's actually a rhythm that we'll see with cardiac tamponade, and I know I'm getting ahead of myself, but I kind of want to build this for you guys, called electrical alternance. Basically, when we've been talking about a rhythm strip, what are we looking at? The electricity, the impulses, right? And based on where our electrodes are, shows how big the amplitude is or where the change is. So with cardiac tamponade, that heart is beating. In certain cases, it moves. So when it beats on this side, it pushes the heart this way. When it beats here, it pushes the heart this way. So as the atrial and the ventricle beat, it kind of pushes the heart back and forth throughout the area. So what happens to my QRS complexes is in one position of the heart, let me erase this and do here. One position of the heart, my QRS complex, comes up here. Next beat comes here. Next beat comes here. Next beat comes here. Next beat, and so on. Don't look at my QRS complex. Look at the height. So every other one is on the same height. Every other one is on the same height. Because when this one, it caught it over here, and then that beat, then it caught it over here. So that heart is kind of moving in the fluid back and forth. That's in tamponade. This actual rhythm is called electrical alternance, or it's basically the electricity is alternating because the heart is moving around. And it happens in tamponade, or it happens in an area where there's fluid into the heart. So it's beating back. If I look this on a 12 lead in the different rhythms, you're going to see a big variance. If I look it on a 3 lead, the variance may be that. Maybe 1 box, 2 boxes. and you don't really see it until you really look at a 12 lead. Some 12 leads, depending on how much it shifts, I mean, some 3 leads, depends on how it shifts, you can see a change. 12 leads, you can always see a change.
What leads would you see in
Oh, it depends. Again, it depends on where its angle is going through. But 2, 3, ABF, B1 are big leads. You'd be taking a look at it. You'll definitely see changes, and I will show you more pictures down the road when I'm talking about. Yeah.
If you're looking at it on 12 lead and you see that in 2, are you going to see like the inverse of that?
What do you mean the inverse?
Like you get the big spike, little spike, big spike, little spike, which get like a little spike, big spike.
You're just basically the big thing you're going to be looking at is that every other beat, it's coming from a different direction.
But
So
on a 12 lead, you're looking at it from 2 different angles. So in one lead, you'll
looking
see-
at it from 6 different.
Yeah.
Yep. So it's going to present different on each angle based on the capture of the position of the heart.
But if you're looking at it from this angle, you'll see the first one is the big spike, but over here you'll see a little spike.
Yep.
And then for the second beat,
If you're looking at it from one side and the other side, they're going to be inversely proportional.
cool.
So that's kind of getting into what cardiac tamponade. So it basically is a building of fluid on there. What you're going to see with this on cardiac tamponade is as that fluid eventually comes into there, it's putting a little bit of pressure. So am I able to move my arms when someone's putting their arms around me? Yeah, but just not much. Then when they get a tight wrap, am I able to move my arms? No. Am I still alive? Am I still beating? Yep. So I'm still moving my arms. I'm just not able to do it much. But because I'm not able to do this, I may not be presenting a pulse. My cardiac output may not be presenting a pulse. So you can get someone who's in cardiac tamponade who has a beat like this, but it does not have a pulse. What's that rhythm? PEA. So this is where my determination, this is where I want to change your guys' minds of things going through. How do I treat PEA from what I told you today? What? No shock. Epi. And what? CPR. So I've got a heart that's being compressed, and I'm making it work harder against this, and I'm pressing on it. What do you think I'm doing to that heart?
Making it worse.
I'm making it worse. Absolutely. So this is where I'm going to change your minds with a couple of things from different concepts of where I call PEA and pseudo PEA of having the definitions. And this is why I think this is important. I've got a whole lecture I'm going to pop to you guys on that because it's a different aspect. But most cardiac tamponade, how are you guys going to know how to diagnose it? So diminishing heart sounds, you're going to see pulse pressure narrowing. You're going to see a couple of things, and we're going to talk about that. Okay? Pericarditis now, it's an inflammation of that sac. So instead of fluid building in there, it's an irritation and an inflammation of that. So basically, that area is getting irritated. So it's going to present a little bit different. And we're going to talk about the positions of how that goes. But when we look at this, it's going to present the initial pain as a chest pain, and it can present just like an MI. And you guys got to determine which route it's going to be. So when we talk about pericarditis, it can come on as a gradual onset. It can become acutely on there. You can see it can come from all these different aspects to it. It can affect all different ages. I hate when they talk about percentages on there because, again, there's over giant studies, but it presents on areas as well too. But it can present in different ways. Causes on there, it can basically happen after an MI. It can come from infections. It can come from different autoimmune diseases. Lots of different things can cause it, as you guys can see. That can bring it up. But basically, it's that irritation on there. Something affected that. So how does it present? Well, here's how the pain comes into there. A little bit different on that. Pericarditis, basically, it's a sharp pain. It's in a spot, whereas MIs, usually people complain of, and again, I hate saying the usually, like I said, but as a crushing or more of a pressure. Pressure on a tamponade is it's pressing on the heart. These are just irritating as it moves. Where does it go as far as radiation to? It's hard to say because, again, those can go to the same spots. So I don't use those for as a change or anything like that. Pericarditis really doesn't change as far as exertion, rest, anything like that. It's pretty constant as the heart beats. But again, take that heart that's being squeezed and you add exertion to it, it's going to increase or exacerbate those conditions. As far as position goes, if you truly have a cardiac tamponade, is it going to make a difference what position you're in? No, it's a squeezing on the heart itself. Whereas pericarditis, if you're back, it's sitting back on the sac, it actually causes more pain. Whereas if you come up positionally and you lean forward, it takes pressure off that. Positionally, it opens up the sac, it takes pressure off the area. So it actually can relieve that pain. So those are one of the questions you'll always ask somebody is, if they're having an MI, position-wise here or here, is it going to make a difference? Sorry for those who are back there. So here, or here is not going to make a big difference. But with pericarditis, it does make a big difference of how it lasts and goes on. Again, onset duration, besides the positional on those and the description of the pain, they all technically could be an MI and pericarditis though, right? So we got to get into a little bit more diagnostic steps. Symptoms: difficulty breathing, shortness of breath, fever, cough, palpitations. You can have almost like a pleural rub that can be with it. They can be diaphoretic, and they usually point to it with one finger. Are those the same symptoms as an MI? They can be, right? Absolutely. Some of those ones can present exactly the same thing. Fever would be one of the areas, and cough, but just because someone has a fever, that doesn't mean that it's an MI. So again, where I wanted to get to this is I'm looking through these. They can present to a lot of different things as an MI. Go through a little bit different than a cardiac tamponade, but pericarditis can present basically as an MI, right? And that's why it's one of our MI foolers. So let's get into a little bit more criteria, because I can't rule this out as pericarditis besides the fact that my patient leaned forward and felt relief. Other than that, I could be, based on all the symptoms and everything I've shown you so far, this could still be an MI, correct? Absolutely, it could be. So now we're looking at it, and this is a 3-lead. You guys have been taught to it as 4 leads. 4 leads and 3 leads. If I say 3 leads, they're interchangeable. So basically what we're going to see, and you may or may not see this, but we see elevation on a 3-lead. Sometimes it comes in this, basically this concave curl, and they talk about this smiley face, or drawing a smiley face on there, where that basically, if you're looking, the ST segment is elevated and it's in a circular or concave shape, forms basically a smile, if you will. That's going to be more likely to be pericarditis over the fact of it being a true MI, where the segment normally is a straighter area and doesn't have that swirl. Honestly, I cannot tell you why, presentation-wise. Someone else knows? They tell me why it presents in that area, but I've never been told, and I haven't researched the reason why it comes to smile. One of the reasons I don't research this is this isn't always or negative, always or never. You got anything there, Josh?
Well, I did most of the Facebook thing. Stuff about ST elevation. It's actually the ST segment is actually the baseline. The other part is down, and it has to do with electrolyte at rest. What's happening from the injured cells. So it's like it's backwards thinking.
Right.
It's pretty dumb.
Well, yeah, technically, yeah, there is no such thing as ST elevation. It's everything else is decreased. Yeah.
Oh.
But if I teach you that, then it's like wait a minute, what? Yes.
I'll read the article on board.
Yeah. No, technically, yeah, there is no such thing as ST elevation. It's ST is baseline. The rest of your rhythm is depressed.
So I'm assuming that's might be something similar, but I don't know. Exactly.
So it has something to go there for the positional, but I don't know why it makes the concave. I've never looked into that. If you guys want to know, I'm going to put that as an assignment for you guys to teach me. But it hasn't made a change in there. And I've seen pericarditis that it hasn't done this specifically. But we see elevation on there, so if we see elevation, what are we going to do? Absolutely. So how well can you guys see this 12 lead? Not well? Okay. So here's now where we're going to look. And what we're looking for, how many boxes of elevation are we looking for? Or if we go to the article and what Josh has said, how many boxes of depression are we going to see? So basically, if we look at this, lead 1, we see elevation. Lead 2, elevation. Lead 3, we're one box, but we are elevated. I don't see it so much on there, but I am here. Look over here, we're elevated. We're depressed. But everything else is elevated, so we're going in here. We're seeing elevation. So if you look through every other area, pretty much, V1 not so much, V1 looks area there, but we're seeing a generalized elevation of the ST segments.
So when it says in all leads, it's more of a generalized.
Yeah, because we may not see it everyone because it's all dependent upon the view and where the electricity is being set. Our amplitude is basically when we're at a 90-degree angle versus when we're at a 180-degree angle of how we're seeing those area scopes and those changes on there. So it's going to change varies by the position of how our leads are done there. That's not artifact what we're talking about, but it's how we see the amplitude and position of it. But generalized, we're going to see elevation through all of it. What we'd be looking for is we'll talk about when we talk 12 leads, we're going to talk about what's called reciprocal changes. What we mean by reciprocal changes is kind of where Alec was referring to. If you're looking at it from one way, it looks the opposite from the other side. So if we see elevation in our anterior leads, which ones are our anterior leads? Do you guys remember? 3 and 4. S, A, T, and my S-A-L, however you want to say it, called salves. So if we see elevation in our anterior leads, what's on the opposite side of our anterior leads? Posterior, inferior. What I would expect to see then is in my inferior leads, depression. If it's raised on that side, I'd see depression. That's what we call reciprocal changes. I mean, it's elevated in one, it's depressed in the other. So if I see elevation in multiple leads across there, it's pericarditis. It means around the whole area has been irritated and it's causing problems across that. So that's actually a fooler. So if you looked at this and you jumped here, don't see it there, but you jumped in here and you see, I definitely see elevation, and I see, right there, and you kind of jump through and you look at it and go, yeah, this is anterior lateral, and you don't look at the inferior leads, or you don't look there. You could call this an MI. But if you look through each one, you see, yet there's generalized elevation in all ST segments. That's pericarditis. And then you go that with your clinical impressions to rule it out. Does that make sense? Am I confusing more than I am? So, and again, this is just an entry to talk about 12 leads because we haven't even got to 12 leads. Okay.
With an MI, you don't get the swooping either, right?
In most cases, correct. So basically, once we see this, what are we going to do for someone who's got pericarditis?
Position of comfort, oxygen.
Position of comfort. We're going to get our standard history on that. Does the patient get aspirin? Why not?
It doesn't have to do with the cardiac muscle itself. It's the sac.
Correct. Can you give this patient aspirin? Absolutely.
You can get cosmetic too.
Exactly. So it's determined. Yep. I want you to determine on whether you would give it or not. So if you diagnose this, does this patient need aspirin? No, not from the condition. What does this patient actually need?
Antibiotics.
They're going to need antibiotics, steroids, whatever, depending on what condition. If this is a bacterial endocarditis, what was the infection area, what was the irritation, other things from that. So the things we are going to do is we're going to treat it until proven otherwise. You're going to be able to diagnose those areas and realize it's there, but you're going to treat it supportively. Yes?
How much there's different variations of how you interpret it versus everybody else interpret it? What if, isn't it better to err on the side of caution and assume it's an MI? Because looking at it, just, yes, there's all these different things that are identified as pericarditis, but it's still an MI. Just, you looked at it and said it was pericarditis, and I said it was an MI.
So if there's two people on scene, and that's what I'm saying on this patient, if it truly is pericarditis, it doesn't need aspirin, but can you treat it with there? That's my point, absolutely. So if there's two definitive areas where you guys are going, one person sees it at one, treat it as an MI. But what I want to tell you is an MI usually is not going to present as generalized ST elevation across the whole area. That's going to be your determining factor. So go by your history, go by your area, but when you get your 12 lead, and as we get more into 12 leads, you're going to see this, is don't go, if you see the generalized elevation across, it's pericarditis, have that in your area, then rule it out. If you can't rule it out, treat it as an MI. You can never go wrong over-treating. You can always go wrong under-treating. Is that correct?
Yeah, I guess I would just hate to assume it's pericarditis and bring it to the hospital and have a full-blown MI. Just kill them.
Well,
Yeah.
you would have got your 12 lead in how long? 3 minutes on scene, you would have 12 lead in.
Yeah. On your 12 lead, you trust me, you will be able to identify this quickly, and you'll see. And if you saw this 12 lead on there, once you guys got read that, you will read that as pericarditis. If you don't, rather have you bring it in. Basically, here's what you're going to do too. We don't activate anymore in the field, right? So if you're bringing this patient in to the hospital because you think it's an MI, what are you going to tell the hospital as far as your elevation? You're going to say you got elevation in 1, 2, 3, maybe V2, V3, you know, everything like that, and tell them across. You'll let them make those decisions for you. And then you also take, if you're doing this, you'll take serial 12 leads, and you can compare it to it for changes. I will never fault you for bringing this patient in, or we'll talk about the other 5 coolers, the 5 total coolers in there. No doc would ever bring you in or telling you from over-treating it. So if you want to call it as go, well, I think it's a cooler, but this might be MI. Would I bring this patient to the hospital with pericarditis? Absolutely. So you're bringing them anyway. Whether you go code 1 or code 3, doesn't matter to me. If you went in code 3 with this, and then they got you there and they told you, nope, this isn't that, hey, you're not missing out on anything. But we'll get to the point where you should be able to diagnose this through a couple other things to where you'll be able to rule it out and you make that decision for yourself. But if you called this and activated for an MI, no one would fault you. Fair enough?
Aspirin's not going to hurt because it's got the analgesic properties and it's an NSAID, so it'll help with the.
Yeah. It doesn't hurt whether you do it, so doesn't fault for that. Do you have a question?
I was actually going to say something like Alan. You saw this, you're like, ah, what's the pericarditis? You get the report to Don, and you say, hey, 325 aspirin just to be on the safe side, plus it's an NSAID. Are you going to get dinged for being an NSAID?
The only reason you're going to be dinged for not giving an aspirin is if where was a contraindication to giving it and you gave it anyway.
Well, right, I feel like I'm losing aspirin.
Yeah. But no, if you gave aspirin to this case, it wouldn't be wrong at all. Because they came and presented chest pain. Fair enough? Again, I hate talking about these specifically as far as where they go, as far as incidents and occurrences, but pericardial tamponade, you're not going to see a ton of out there. It's not that common on there. Some of the other things when I talk about pericardial tamponade that you probably see more commonly than the actual tamponade itself is basically, and hopefully we're starting to see it go away, but where I would see it coming in before is what we call the pseudo-tamponade. So what I refer to as pseudo-tamponade, I talked about pericardial tamponade, and we're going to talk about that next. But pseudo-tamponade is anything else that presses on the heart and causes the symptoms of a pericardial tamponade, but it's not due to fluid within the pericardial sac. Does that make sense? So basically things that can cause that, one of the things that I'm a big proponent for is not bagging my patients during CPR unless I have a definitive airway. And definitive airway for me would have been King Airways, LMA, depending on where you practice. Reason being is, where does most of that air go? Stomach. And that stomach goes up and it goes out. So it actually puts pressure onto the diaphragm. And what does the diaphragm do then? It squeezes onto the heart, and it squeezes the heart, similar to a pericardial tamponade. Same thing with, tension pneumo. Where does the pressure of the lungs go when it's overinflated? Presses on the heart. Hemopneumothorax. Pressure on the heart. So it can give things that can mimic a pericardial tamponade. So those are all things to look at. So you rule those things out before you consider that, because we'll talk about the treatment of what you do for pericardial tamponade. But if it's not truly pericardial tamponade, but you see those type of symptoms on there, you can fix those other things, correct? So if it's the stomach's insufflated, how are you guys going to fix that? NGO tube, NG tube, OG tube, and you're going to suction out. You can fix that. If it's a tension pneumo, how are you going to fix that? If it's a hemopneumo, how are you going to fix that? Chest tube. So there's different things you can do to relieve that pressure off the heart. So those are things what I call a pseudo pericardial tamponade. But now we're going to focus on just what
We can't do chest tube, right?
certain medics can. If you're a medic on life flight, you can.
Okay.
Critical care transports can.
So we can
You will be taught that. You can actually do a needle decompression here and fifth intercostal space. You can't do in our area a chest tube, but it is within the paramedic scope of practice to do a chest tube. You guys may do chest tubes, or one student did a chest tube during their ER rotation. Flight medics are taught chest tube. Certain critical care transports are taught chest tubes. So
Pericardial centesis, is that
it is a skill you guys will be taught, but it's no longer in practice. It was practiced when I was a medic a long time ago. They've taken it out of our scope of things right now.
is that just in this area, or is that whole national?
That's our area. We can't do it. Some medics can do it in other places, but it is a paramedic scope of practice. It's just whether we can do it or not. We can't do it here now. Yes, you do that in the field, and I'm going to talk to you about 3 different ways that it can be done. I was trained on it, but never ever came across one. So basically, we kind of talked about that. The heart is being compressed. Usually what happens is there's some type of injury to the heart, and the heart is actually bleeding somewhere. A lot of times it's one of the carotid arteries that basically has a tear or an injury, and that area is filling inside the sac. It comes down. It can be from there. It can be from an injury directly from the heart itself. It can be from a contusion and a stretching, an injury, and blood's leaking out of the heart that way too. Lots of areas that can come up and actually fill that area. I talked to you about that normal being 20 to 35 mils that floats into. Double that dosage, and that can cause pressure on the heart. So it doesn't take much to be in there. So you remove as much as 20 out of there, and you're going to make definite changes and improvement on the heart. And that's usually what a pericardial centesis is done, is basically attaching to like a 30 to 60 cc syringe. When you come in and you're pulling out, you'll pull out much fluid, and you'll eventually pull it off and pull out more fluid over a period of time. But it doesn't take a lot to actually make a change and make a difference. I'm only speaking from videos that I've seen because I've never physically done this. Other signs we're going to see, Beck's triad. You guys gone over Beck's triad? Okay, so what's Beck's triad?
Hypertension, decreased pulse, or feeling.
Muffled heart tones.
Yeah, that's what I'm trying to say.
Okay, what else? Perfect. Okay, so you will see this again. What's fixed principle? No, I'm just kidding. So basically, the big thing that you guys are going to see with this as well, narrowing pulse pressures. That's going to be one of the quickest ways you guys are going to see from this too. Besides talking from history and from getting a few things, you're going to start seeing those pressures. The systolic is going down, your diastolic is going up. And those are actually getting closer and closer together. There's going to get to a point where if this lasts too long of a period of time, those pulse pressures may narrow out at 80, and they're meeting at 80. So when you have that, what's your pulse? Nothing. Your systolic's at 80, your diastolic's at 80. Nothing's moving, but your heart is still physically beating. Electrical alternance. So, or what do we call it? PEA. So I'm going to teach you that PEA actually is its own rhythm and it's not asystole. HA teaches you PEA and asystole are the exact same thing. I'm going to teach you they're different. So basically with that, or the pulsus paradoxus is basically your radial pulse comes weaker, it disappears as your patient's inhaling on their tube. Why do you think that is? And it tells you right there, doesn't it? It's the area basically as you're doing that, increased pressure is going to basically trap that area and it's not going to pump blood. So it takes your pulse away from that access. They're going to be in respiratory distress. Why? They're not pumping blood, right? It's narrowing out. They're getting less and less in. They're not getting out, so the body's coming through. Chest pain because that heart is being irritated, being held. And then they're going to start to show signs of cardiogenic shock. What's cardiogenic shock going to present with?
Pale, diaphoretic.
What's the difference of cardiogenic shock versus hypovolemic shock?
Cardiogenic is due to the heart not
Pump going on.
whereas hypovolemic is a loss of fluid
So how are they going to present?
differently.
Differently how?
Well, cardiogenic would probably see bradycardia.
Okay.
It's going to be thready pulse, or says it's going to be nothing.
Which on this, actually, I'll let you know, they won't actually be bradycardic. They actually can be tachycardic. Would be different. Cardiogenic shock, I know what you're talking about. But with these, with pericardial tamponades, they can actually be more tachycardic because it's trying to beat and move around. But your pulse is going to disappear and go away.
Are they also going to have or feel like heart attack symptoms while they're in shock?
Oh, absolutely.
Okay. So like,
But if they go pulseless, they're not going to feel anything.
So sucks.
Yes.
Yes.
No, that's only if they've been dead for some period of time. No. So basically on this, though, they are going to present no different than a hypovolemic shock in a sense of things. Because hypovolemic shock, what's their heart rate going to do? It's going to go up. They're going to present, their pressures are going to go down. This is going to present similar to those aspects. So realistically, the difference between a lot of this, how this patient's going to present and how other patients present, is going to be you guys asking questions of how this started, what they come in, what were their original pulses. Hopefully you were able to catch them at a certain time and get an actual blood pressure and see they're coming up. Whereas a hypovolemic shock, you're going to see actually the diastolic going away, not getting higher. It all just depends. And if you got on scene and you got someone who's a PEA already in this stage, how are you going to tell there? There you got to be looking at 12 leads and 3 leads. So another thing I'm going to be kind of just pushing out to your way. So how are we going to manage the pericardial tamponade? First thing we're going to do is we're going to rule out everything else. What I call the pseudo tamponade versus the actual tamponade. Rule out everything else that's going to be. And one of the big reasons I'm looking at that too is I could fix most of those other issues. I can't fix this in the field right now, right here in Spokane. Personally, I can't. So, but this is going to make a difference for what I can do. I'm going to get the airway secured. I'm going to take everything I can do. And then you prepare for pericardiocentesis. That's the only option here. How do we prepare for pericardiocentesis in the field? High flow diesel. That's it. Basically, it's calling the hospital and telling them, this is what I'm bringing you.
Cut the shirt off.
So we're going to go to the trauma center as rapid as possible. Where can we take this to if we're out in the valley? Can we take this to valley? Okay. Go wherever you need to go, though. Here's the question.
There should be a scale for any doc, right?
It is. And you can take the hospital. So if I've got a patient who went into PEA with a pericardial tamponade, oh yeah, I'm going to go to Valley Hospital if I can't get there faster than I get Sacred Heart. If it's on the way, I'm not going to bypass it. If you call in to the area, absolutely you can. And well, one, are you going to be transporting a PEA? Correct. Here's where my philosophy is going to go to you guys.
Are you guys going to transport trauma patients? Well, then they're in arrest. No.
No.
They're driving drunk, dude.
Our policy is we fix them on scene, but here's where I want to go with this because there's been one case where we transported a patient who was in PEA because of a pulmonary embolism. And they transport because they were not going to fix her until that hospital. So this is something, again, where I'm going to go to you and talk to you. Can you transport a dead person? Absolutely we can.
The only time I've done it is
Okay. Well, no, that patient had a pulse. Can I transport a patient without a pulse? Absolutely, I still can in Spokane County. Why? Because I'm thinking outside the box and I know that nothing I do on scene is going to save the person. The person's already dead, right? Pumping on that chest and pushing epi is not going to save that person. That person, if they have this situation, the only thing that's going to save this person is a pericardial centesis. Do I have a needle on my ambulance or on my fire department big enough to do this? No, I don't. So basically what do I need to do? I need to call the doc and say, here's what I've got. Where do you want me to take it? And you leave it into someone else's hands.
How effective is CPR going to be on this patient? Because
Minimally.
float around there, are you going to be moving?
You're still going to be able to pump because you're still pushing some area in there, but it's going to be minimally effective. How long will they last in PEA? I don't know. Eventually they'll stop and they'll go to an asystole. And you put more work on the heart.
How long of a needle do you need?
Long needle. About this.
So basically, what the doctor's not going to look at is downtime. You got this guy, or a car accident, trauma, something like that.
Trauma's a different story. Yep. Yeah, you get.
More likely
You have to look at a lot of different factors. What I'm just saying to you, where I want you guys to know, is there are alternatives to where we can go outside of our protocols. This is one of those. If you can diagnose what's wrong on here and you know what's going on, and it's something you can't fix in the field, and that patient's going to die unless you get them to a place, you can go somewhere.
I would say, especially like if you were with this patient who were on the
Awake.
edge, you thought this was it, and then they go down.
You followed them down to that
You're 5
area.
minutes away, why wouldn't you?
Yep. And that was the lady in the PE who gave birth at a smaller hospital and watched her develop the PE, developed it right there on the spot, and she died. It's like she's going to be dead unless they transferred her to the Sacred Heart, and they did, and they pulled it out. So she lived. She wouldn't have lived had they not taken her to the surgery, though. And it was apparently the picture I saw with the clot was about that big. 26-year-old female, second pregnancy.
So they just did CPR the entire way.
Yep. So those are different things that you're going to be doing. Other type of management on there, again, once we get that tamponade off, we're going to keep watching that to see why the fluid was coming in. This is a patient that's definitely getting into the hospital, potentially going into the OR if they've got leakage or something coming into it. So it's hard to diagnose this. Basically, if they're having a tamponade, we're going to ask basically the history, what's happened, what occurred across this area. We're going to be trying to see, hopefully we have some set of vitals, something to compare on. Again, one set of vitals is an image, 2 is a comparison, 3 is a trend. So we want to see a trending set of vitals if we can. We want to see basically, did they have JVD, did they not have a JVD? What are our suspicions going on there? And what are we seeing as far as 12 lead on here? Why did that go here? Sorry. Is that my last? Okay. Then I'm going to go back to here on this. So those are different aspects of where we're going on this. But basically, there's 3 different ways to do a pericardial synthesis. One is ultrasound guided, where you're basically going to take an ultrasound. And the reason I'm telling you about this now is we don't have ultrasound in the field. They are basically getting a handheld model that's becoming less and less to be more affordable. And actually, the one I just saw down at the last conference was about this big, and it basically Bluetooth to your phone. And you basically could set it like this and put around, and you could see it, and it went right to your screen. It's just an app, and you could see it on your phone. So for others, it'll go to tablets or go wherever. It's getting really cool as far as it goes. This may bring back pericarditis to us. One of the reasons we don't do it, how many times has anyone here seen a pericardial tamponade, actual pericardial tamponade? The incidence is low. So why train, why frequency, why carry all this stuff and do that stuff if we're not going to do it? But I think ultrasound is going to be an area that's going to possibly help us with that. But one of the things you'll basically do is you'll put it right here on the chest. You'll take your needle inside, and you can actually watch the fluid into the heart. And basically, because you have it angled in the way, you can watch your needle come in, and you'll see right when that needle, and it's really easy. With practice, it's easy to see. You can see it. It goes right down into the spot. I used to do injections under ultrasound. It's a learning curve, but you get it. It's fairly easy. You watch it go right into the heart, into the fluid, and then you start pulling back. That's one. Until that comes up, what we were trained was with our life packs is you actually took the lead and you put the lead onto the needle. As you basically, you take your negative lead. So you've got your 3 lead on your patient. You take your negative lead and you actually attach it. So the metal's on the metal on your needle, on the metal part of the needle. As you are inserting it into the heart, and this is actually what they'll do at Sacred Heart when they do this. Joel talks to me, this is how he does it, because they don't have ultrasound bedside always. They'll hook it to that. Basically, as he's injecting the needle, it's a 45-degree angle from the xiphoid process down to the heart. As he's injected it, he's watching the EKG, and as soon as he gets close to it, the rhythm will start changing. It'll decrease and the amplitude affects as that needle's coming in, because it's now affecting the electricity. It's conducting across. And he'll know he's right in the right spot, stops there, starts to pull back, fluid comes out. So that's another way so you know you aren't going too far. The last way, what's that?
How big was syringe? Good size?
Anywhere from a 30 to a 60C syringe is attached. The last way you do it is you do it a blind method to where you aim down at that angle, and on the syringe you're just constantly just pulling back as you're inserting, looking to that, and then once you pop into the pericardial sac, you'll feel that flow out. But you just got to be moving really slowly through the whole process. Usually on these, you'll do a little injection to numb prior to. Depending on the case, if they're dead, you're not going to. But what numbing medication do you guys know that we carry on our lidocaine? Lidocaine 2% is an anesthetic. You actually take that, you drop a small amount, put a wheel into the area, and when you put the needle in, they don't even feel it. We used to do that for IVs in the hospital. We shoot a little lidocaine as a wheel right around the spot, and I put the needle through that. They don't even feel the IV coming in.
I may just
Surround thing on your car?
A wheel is basically what we call it. So it's a subcutaneous. You just pop it in, and it forms this little bulge.